Doug, I'd like to take you back to some general attributes of that 1918 pandemic that you have studied. I mean, one of the things that was very striking in reading your essay was how quickly it spread in about a month, and that initial duration, which I gather was about 4 months, further the mortality that you've alluded to, and then what looked like kind of idiosyncratic reactions across US states that didn't seem that associated with, for example, population density. So some of the states that were the most hard hit, like Pennsylvania, Montana, Maryland, Colorado, had really very little in common with each other. So I wonder, could you share a little bit more about what were the general attributes, and then what explained, in your view, some of the highest mortality as you look across America in 1918?
Something that I think is a abiding puzzle among people who study 1918 is why the geographic variation was what it was, and it was quite substantial. I think Kansas had something like 10 times the increase in maternal mortality that Wisconsin did. St. Louis had a much milder experience than did Philadelphia, et cetera. And even Minneapolis and St. Paul had very different experiences, despite being the twin cities. So from the standpoint of looking at long-run effects, this was kind of a blessing, because the usual things that we might think are associated with later life outcomes weren't so important. So population density, et cetera, fraction immigrant, et cetera. But I would say there are two things that have come to light as important. And some of this is work subsequent to my own, and not by me, but I think is still very important for understanding both 1918 and for thinking a little bit about today. And the first is something people have heard about, which is the interaction with pollution. There's some work by Karen Clay at Carnegie Mellon and co-authors that argues that in cities that had more coal-intensive electricity production, they have something like 20% higher mortality rates during the 1918 pandemic. And people will probably know that there have been some recent studies coming out of the Harvard School of Public Health arguing that in the current COVID crisis, you see this variation along the lines of pollution as well. And I think those recent results are sort of more descriptive and will need more analysis, but I think it's intriguing that both seem to, at least what we know right now, to have been exacerbated by ambient air quality. And that's not so surprising because this is a respiratory disease. And so if you have poor baseline respiratory health, having this virus makes things worse. The second, and this may be especially useful in terms of policy, are the non-pharmaceutical interventions that cities undertook in 1918. Unfortunately, in 1918, as is today, there's not really a frontline pharmaceutical intervention to tackle the virus head on. Indeed, in 1918, they didn't even know it was a virus. They were still debating whether it was a bacteria, and they didn't have microscopes that could see a virus at that time anyway. And so the medical care, particularly in 1918, was not particularly helpful. It was more palliative than it is today. And so that's an advantage we have relative to 1918. But the thing that's in common, I think, are these non-pharmaceutical interventions, which when you read about them for 1918, they're awfully familiar for the things that we're doing right now, including hand washing, face masks, banning large group gathering, self-quarantining at home, that sort of thing. And so there's a study by Hatchett in the PNAS, the Proceedings of the National Academy of Sciences, of about 10 years ago, which studies in 17 cities these non-pharmaceutical interventions and makes the argument that places like St. Louis that adopted these earlier in the pandemic experienced a lower mortality rate later on, and interestingly also a flattening of the mortality rate, whereby it was spread out more over time than if those non-pharmaceutical interventions had happened later on. And so I think, that's work that argues that taking together a series of non-pharmaceutical interventions can alter the timing. And then they have an interesting caveat to it too, which I think is useful to mention. The places that had the better non-pharmaceutical interventions and had the flattened mortality curve, they also had bigger second waves. So when the pandemic came back, there was a larger pool of people who were uninfected, and it came back earlier and it came back larger. And so in the United States, there were two pronounced humps. One was in the fall of 1918, and the other was in January of 1920 when it came back. So I think that's something that's useful to think about when we think about the success of non-pharmaceutical interventions. And I'll make a pitch for a SIPA alum, Solomon Shang, who's at Berkeley, who's put out a working paper on non-pharmaceutical interventions on the current COVID crisis. And he has a very ambitious study. It's with a set of co-authors where he looks at China, Iran, France, the United States, and some other countries. And he makes the argument that, as in 1918, those places that had more aggressive non-pharmaceutical interventions early have had a slower growth in the caseload. So I would say it's those two things which, at this point, and it's definitely still an active area of research, seem to have been helpful. The lower pollution levels and a robust suite of non-pharmaceutical interventions.
Thank you very much. Those are really important observations. So could you just, if you therefore ask yourself, well, how does the 1918 influenza differ from COVID-19? And how is it similar? And what were the kind of interventions that you think we should be doing, learning from that period? Could you just say a little bit more about that?
Absolutely. So I'll just run through briefly some things which I think are similar. I think both of them were surprising to people. The 1918 flu, really peaked in October 1918, but in late September, the Journal of the American Medical Association was saying, this is nothing worse than the usual flu. And I think, people are obviously surprised, certainly in China by the current COVID crisis. The second is just how quickly it diffused in both cases, really in a matter of weeks. As I mentioned before, that pharmaceuticals don't seem to work so well. That's in common. An additional one, which I guess I would like to highlight, is scapegoating in the context of the flu. In 1918, people probably know it's referred to as the Spanish flu, but it didn't originate in Spain. It's much more likely to have originated in Kansas or somewhere else. So there's that aspect, but given the context of war at the time, there was a lot of speculation that Germans had introduced this into the United States on a U-boat or through aspirin from the Bayer Company and that sort of thing. And so I think there were subpopulations that were targeted as a result of the 1918 flu. And unfortunately, I think we see some of that today too with anti-Chinese vitriol. And there was a recent study that documented that most of the COVID that has come into the United States actually came via Europe, but they're not experiencing that same vitriol. The case fatality rate, I think that's tough to know whether that's similar or different. You have a wide range of estimates for 1918. You have a wide range of estimates for today. So I think that's something that we'll have to learn about over time. In terms of things that were different, I would highlight that the experience of the United States with respect to the rest of the world was a relatively mild one, whereas today, it's the reverse. The US has one of probably the worst experience with COVID so far. Within the United States, New York has been bad this time around. New York was pretty good the previous time around, and that's been credited to the robust public health interventions. Another thing that's different and possibly of interest, there's been discussion this time around about substantially higher mortality rates among African Americans with COVID. It was actually the reverse in 1918, and that's a source of continued puzzle of why mortality was so low among African Americans in 1918. Additionally, something that works against us is, the population is just a lot older today than it was in 1918, and our immune functions aren't great as we age. So that could be something that works against us today. So then the third part of your question was I think about interventions, right? Yeah, and so, I've already mentioned the non-pharmaceutical interventions. There were sort of, more draconian things that were tried. So, the Port of New York tried to close off all traffic coming in, and that was done very early on. Australia tried to cut off traffic, and they succeeded for some time, but then right at the end of 1918, a case got in and it took off. So basically, the more draconian attempts to just halt the spread through blockades were largely unsuccessful, both in COVID and today. And I think the thing that's been more successful has been these non-pharmaceutical interventions. Yeah.
Thank you very much. I think it's very important to talk about the international dimension. Maybe we could come back to the international dimension of the 1918 influenza. But let me turn to Scott Barrett, who's worked with a lot of international bodies such as the World Health Organization and studied the spread of infectious diseases, whether polio, malaria, Ebola, SARS, MERS, and so on. And I think a lot of your work, Scott, has studied and thought about what are the dynamics involved in achieving cooperative outcomes multilaterally, and how do you, increase the incentives for collective action, including in the area of infectious disease. So I wonder if you could share some perspectives around the multilateral potential for working collaboratively around a global pandemic such as COVID-19 and others that have come before.
Well, I think the kind of obvious thing we're seeing with COVID-19 is how little multilateral cooperation there is. This has been a patchwork even within the United States in addressing this crisis. And globally, there has not been much coordination yet. I did want to maybe offer a perspective that draws from history, both connecting the pandemic influenza from 1918, 1919 that Doug's been talking about to COVID-19, but also a more recent emerging infectious disease, SARS, from 2003, 2004. One of the things about infectious diseases that's so fascinating is that there are lots of them, and there are new ones coming all the time, and they have different features, and those features interact with our societies and our systems, including for international cooperation. So I think it might be useful if I talk about the comparison between COVID-19 and just these two different epidemics. With the one thing I would emphasize, an important similarity between 1918, 1919 and COVID-19 is a really critical one and a striking one. The epidemiological characteristics are fairly similar, pretty much as Doug has mentioned. There's another thing that's similar and very important is that with the both with the influenza virus from 1918, 1919 and COVID, the people are transmitting this virus before symptoms are showing. And this is really critical because you can't tell when you are sick yourself. Oh, sorry, you can be healthy and you can't tell that you're transmitting to other people. Other people see you, they think you're healthy, they don't know to stay away. So completely different from some other diseases like Ebola, where it's going to be very clear that someone's sick. And so the nature of transmission is totally different. And if you use some basic epidemiological tools and take into account the difference in world population today versus then, you can do simple calculations to predict how, even with the social distancing and the kind of measures that Doug was discussing that we've been taking, the expectations that surround these two different epidemics. And a simple calculation, now the estimates for the total number of deaths worldwide from 1918, 1919 are in the neighborhood of 20 to 100 million people. And again, as Doug said, that's over a very, very short period of time. So quite an astonishing shock to the global system. And a simple calculation for COVID-19 that I did back of the envelope, so it's not worth anything more than that. But that predicts about 46 million deaths from the current epidemic. Now that is assuming that our responses are very naive and primitive. And if we can improve, even with the tools, the limited tools we have, if we can improve things like social distancing and hygiene and the rest, we can bring the numbers down. And ultimately what we're hoping for is the introduction of new tools. That would be transformative, especially vaccines, but others as well. SARS, which is a coronavirus like COVID-19, and has a very similar origin, which is also important. In both cases, the likely origin was transmission from animals to humans. That's, by the way, that's routine, that's normal for most of the harmful infectious diseases. They have what are called zoonotic origins. And in both these cases, probably the original source was a bat, and probably there was an intermediate source. And the transmission to humans came through the wild animal markets in China. And one thing to point out at the multilateral level is that China closed those markets temporarily during the SARS outbreak. It has closed them now during COVID-19. But after SARS, those markets reopened. And one thing that we can do to reduce the probability, we don't get certainty, but reduce the probability of another emerging disease from this source is to simply close those markets. There are other measures that can and should be taken, but that's one simple one. And that's an area where I think international community needs to step up. But the last thing I want to say about SARS is really critical for making a comparison. With SARS, you had an eruption at about the same time of year as COVID-19 in about the same place, so very similar. It also spread widely, but the total number of cases was 8,000. The total number of deaths was 774. The influenza virus, 1918, 1919, pretty much ran its course through combination of herd immunity and evolution in the virus. But with SARS, it was interventions that did it. And the critical difference between SARS and COVID-19 is that people were infectious with SARS after their symptoms showed. And in fact, they were most infectious when they were most sick. And that meant that we were able to identify people who were infectious, isolate them, determine the people with whom they had been in contact, and in turn isolate those people. And that's how that disease was brought under control. So even though the epidemiological characteristics of SARS are actually very similar, higher case fatality rate, by the way, but otherwise very similar to COVID-19, the world was able to shut that down primarily because that disease had this feature, fortunate feature, that it was primarily sick people who were transmitting. So I think when you look at the performance of individual states, nations, and the international system, it's not just those entities independently. It's how they interact with the features of the pathogen, and also with the tools that are available at the time.
Thank you very much. Very important observations. I'd like to invite you both to go a little bit further into the implications of where we are today in light of what Scott has just said. What I'm thinking of is, you know, I think we should all be worried about a second wave, particularly with that asymptomatic characteristic that you've just talked about. And there's a lot of discussion now about how do we prepare ourselves for the next phase of perhaps loosening a bit whenever that were to occur, and the importance of contact tracing, of surveilling, of finding some sequencing of how people go back into public places to reduce density, keep social distancing. So all of this is going to be difficult, both on the science, but also on the public policy, the privacy, the data collection and use. All of these features will come into play with very significant differences across countries as to their willingness to use some of these tools simultaneously, and certainly very heterogeneous views in the United States about timing, contact tracing, surveillance, data sharing, et cetera. So I'm wondering if each of you could comment on what you think of as the dimensions that you would wish to emphasize as we move past the peak, at least hopefully in New York, but not 100% clear, but into a phase in the coming months that will not put this behind us, but will increase the need to figure out how to manage it until we have significant pharmaceutical interventions that are powerful.
I'll start off. Well, great question, Mara. One thing I wanted to say about a second wave is that there's a really serious endogeneity involved in this. And in fact, this is true with all infectious diseases, that the ability of a disease to spread depends not only on the features of that disease, but how we as societies respond to the threat. And there's a concept in economics called prevalence-dependent demand. And we normally think of it for vaccines. And what it basically means is, if the disease is widespread and the risk to an individual being unprotected is high, there's a high demand for a vaccine. If the disease is rare and there are any worries or anxieties about a vaccine, people don't get vaccinated. And there's a tendency, and this can be demonstrated actually pretty simply, there's a tendency for there to be too little vaccination in any, and by the way, vaccination, you can think of as almost a metaphor for public, for interventions. But there's a tendency for there to be too little relative to the social good. And the reason for that is that there are these externalities. So I'm just reminding people how important economics is. There are these externalities in actions like vaccination, that if you protect yourself, you also break the chain of transmission, which in turn helps other people. That's where the concept of herd immunity comes from. So I think the risk with COVID is that as these controls that we're adopting now in places like New York are more effective and the virus recedes, at the same time, there'll be a response by individuals and by political authorities to want to loosen up. And as we do loosen up, there'll be more of a resurgence. So I think that's to be expected, and it's a phenomenon that South Korea has already encountered and has been controlling pretty effectively. Now, the last thing I wanted to say about this that's really critical, and it goes back to what I was saying before about the difference between SARS and COVID-19. With SARS, you could see who was infected and so on. Well, with COVID-19, we can't, or at least we can unless we have effective testing. So testing is going to be critical. And it's testing both for infection and for antibodies. And with testing, you can adopt this approach that was used to control SARS, as in quarantine and contact tracing. And related to that, Merritt, is your concern, I think, that this also creates a conflict with concerns about privacy and individual freedoms. And I think this is the essence of public health and how it differs from private health. It's that private choices have public consequences. And in order to protect the public, it's essential that our public institutions, governments, actually limit individual freedoms. That is exactly their role. And it does create a tension, but that's exactly what's needed in order to control. And if that isn't given, then control will be ineffective.
Thank you. Doug, could I invite you to share your thoughts on this?
Yes, thank you very much. And I don't have a lot to add to what Scott just said. I think that is really the most challenging question to my mind. And I guess I have some hope, in part because, you know, testing capacity has improved so much. So if we sort of think about, you know, the process of reopening as sort of getting another crack at what we should have been doing in January and February, we have learned some things that will be useful. We also have the benefit, if you will, of other countries being a bit ahead of us. China and Italy are already exploring ways to loosen up mobility restrictions and that sort of thing. So I think we should be paying very close attention to their experience in real time to see what seems to work and what doesn't work. You know, maybe there's some additional things we can try as well that are informed by 1918. One of the things that they did then, which I'm not sure how effective it was in isolation, but the Board of Health in New York dictated staggered start times for schools and for businesses to reduce crowding on the subways in peak transit times. So maybe there are additional things that we can think of trying as well. I mean, but ultimately, I mean, what we keep hearing and seems to be the big moment is, you know, we want to run out the clock until we have a vaccine. And, you know, from an economics perspective, it doesn't make sense to just shut down everything until there's no risk. You want to start getting things back up, even if there is some risk, and you want to balance that risk against the benefit of starting back up, but then quickly have the capacity to close things back down as needed.
Mm-hmm. So thank you. So, you know, I just want to ask one more question about that dimension. You know, we're hearing, for example, in some places, I think in Singapore, for example, citizens might be alerted if they went to a movie and someone a few rows down tested positive. So clearly they're able to test their population and they're able to share the information in some way with others who might be affected, that contact tracing. So I guess just as a last thought, I'm inviting you to think about whether it's looking at what happened in 1918 or what's happening today. If we're able to develop the methodology of testing, do you think we can roll it out in a way that allows us to actually affect people's behavior? And what do you see as the role of the state versus, you know, private firms in engaging with that kind? Because we're seeing, for example, Apple and Google are collaborating now on a COVID collaborations on tracking. We'll have to have both public sector and private sector responses if we're going to engage with comprehensive contact tracing and surveillance, et cetera. And I wonder if each of you have any observations on public versus private responses.
Well, this is going to be really fascinating to watch how things unfold. We've been all immersed in this crisis, but this tragedy has a way to go. And the next phase is going to be really interesting. Doug was right. And it's really important that because this, the way this virus has moved, which has been, of course, very rapid, but nonetheless, we've seen how other countries have responded and the consequences of that. So we can learn as we go, not only from our own experiences, but also by observing others. You have at one end the crackdown on movements in China, and then you have the more targeted kind of interventions in places like South Korea, Singapore, Taiwan, which have relied on extensive testing, but that's quite invasive. I mean, that means, you were saying, Merritt, you're acquiring information that people might consider to be private, but it is of public interest. And they're using all sorts of technologies, and there are all sorts of apps that are being produced by the private sector to acquire information and to share that information. So examples would be, there was interventions in for contact tracing in reading, well, following cell phone movements, but also reading Bluetooth communications to learn about people's proximity to one another and so on. Well, this involves, you would need to have a pretty massive, it's not just information, you also need a pretty massive intervention by a significant force of people who would actually perform the duties of bringing about quarantine, contact tracing, and so on. This is not surprising if you read all of history, humans, and the coevolution with infectious diseases, but it does expose these fundamental tensions between the individual and the state, between the private and the public. And I think that, ultimately success in controlling an infectious disease, because of the public good aspects of that, require public intervention. And just quickly, on the global multilateral situation, where things are going to get really super interesting further down is with the availability of new tools, and most especially vaccines, and the distribution of those in particular. The availability of that and the distribution worldwide is going to be a critical issue for the future.
Thank you. I'm beginning to see a few questions. If anyone has questions, please use the chat feature. And Doug, let me invite you to make a final thought before going to some of our questions.
Sure. Thank you, Merritt. So again, I have little to add to what Scott said. I think obviously the technologies we have today can allow us to have a better sense of when to turn off the valve, as Governor Cuomo says. There, of course, is that tension with the privacy concerns as well. And Merritt, to your question about private public partnerships and that sort of thing, I have seen what looks like companies really doing terrific work. And one of the things that a group at Berkeley has been doing is drawing on this data set from Homebase. And Homebase is a scheduling platform that companies use. And they've been using this to assess, at a very high frequency with very recent data, where the economic effects are greatest and where they're less. And so where we sort of want to target public policy resources, and which sectors of the economy which are more suitable for working remotely, how these are less impacted. And I think having understanding of the timing and distribution of these economic impacts through working with companies like Homebase, I think this will allow us to do that cost-benefit analysis for how to sort of turn on the valve a little bit. And that's in stark contrast to 1918. There's studies of the economic effects in real time of the 1918 pandemic. And my main reaction to those is, wow, the data then really weren't as good as they are today. But the basic neoclassical predictions of maybe there was an increase in wages and maybe there was a fall in the return to capital. People tend to find that type of thing. But we're in a much better position to understand those economic effects today than we were in 1918.
Thank you. I think one of the questions I'm seeing is, in effect, what was the 1918 impact on the economy, and did it have this similarly devastating effect? If not, why not?
Right, so I can give a quick answer to that. The real-time data that existed on the economy were pretty much non-existent. So the studies that have looked at economic effects in 1918 were doing things like surveying newspaper articles to see, okay, it's reported this business shut down and that sort of thing. And so where the data were a little bit better, and again, you know, that pandemic was relatively short, and the non-pharmaceutical intervention measures, I think that PNAS paper said had a median length of 6 weeks. So the shutdowns weren't that long. They were something like on the order of 2 months. Sorry, I lost my thread in the question. What was the question again?
Well, it was no matter. That was a good response. We'll keep going because we're getting.
Sorry, I've got it now. So people have been able to look at the longer run economic effects, and they've found positive things like on wages. Elizabeth Brainerd has a paper on per capita income growth during the 1920s, and finds that there's more rapid per capita income growth during the 1920s. So there were some economic upsides later on, but it's difficult to disentangle the recovery from an actual sort of productivity effect.
Great, thank you very much. So I'm seeing a lot of questions. Some of them are quite lengthy, complicated, knowledgeable. Thank you all. But here's one direct to Scott. Ned, do you think that this crisis is going to improve cooperation, international cooperation, in this area or other areas, or do you think it's going to be, adversely affect the scope for international cooperation?
So that's a great question. It's from Danny Bresler. Hey, Danny, thank you for that question. Well, I don't know the answer. I mean, we have everything to play for, but I don't think there's a certain outcome that we can expect. I think it could go in different directions. I think the impulse of the moment is very much about national interest and self-preservation, and that's understandable. But to tackle this problem in a coherent way is going to require large-scale coordination. And I think where things are going to get really difficult is when you see large number of cases in countries that have poor governance and don't have access to resources, and how the international system responds to that, whether assistance is given, and how it's organized. And on top of all that, I think where things are really going to come together with profound consequences will be when a tool becomes available. And whether that tool, a vaccine, there'll probably be multiple vaccines. And scaling up production is not trivial. So there's a lot of effort that has to go into development of a vaccine. If there's a new influenza pandemic, it's not as difficult to deal because we're used to those. But with this coronavirus, we don't have a vaccine. So there's a lot of fundamental work that needs to be done to test for efficacy and also for harmful effects. But once that becomes available, how it's going to be allocated, I think this is an opportunity for the major powers to come together and to decide that they want to produce this and make this available to every person in the world. I think that's within their power to do, and I think that would be transformative for how people understand what we all have in common and how, when we work together, we can achieve more. But the impulses that we're seeing so far, and that we've been seeing for over a decade, are much more in the direction of self-interest and nationhood. And I think we could go in either direction. Obviously, I hope very much we'll go in the former direction. I think that will be very critical for achieving a lot of other issues of great concern to the whole world.
Thank you very much. I think we've reached the end of our time. I want to really thank Professor Doug Almond, who's done really remarkable, important work on the 1918 pandemic and its intergenerational effects, and Scott Barrett, who continues to look across regions of the world, as does Doug. I think a lot of our faculty actually have initiated projects that are putting their expertise on the problems we're experiencing today in the United States and around the world. So I'm hoping we shall have a series of conversations with our own faculty. I want to thank both of you and all of the 135 people who joined us today for your patience with us and this technology. And thank you all very much for joining us. Good afternoon.
Thank you. Thank you, everybody.
Thank you, everyone.